Epilepsy is a disease, a common neurological disorder, and it affects anywhere to 1 to 5% of population, so it's pretty common. There's about up to 3 million people in the United States living with epilepsy and up to 50 million worldwide. As I was mentioning, the symptom, the presentation of the disease is a symptom, and symptom is what people have, what we call a seizure. Seizure itself is a transient disruption of the brain function when there is abnormal excessive firing of the large number of brain cells. Seizure itself does not mean epilepsy. When we say seizure, it could be provoked by something else. For example, an infection or anything that stresses out the body significantly enough that can provoke abnormal firing in a brain. And then seizures can be unprovoked. That's when there is a basically genetically determined or acquired disorder. So the brain has ability or basically the way it's wired, it can cause seizures by itself. When we say seizures, I said it doesn't mean epilepsy. In order for someone to have epilepsy, we need to have unprovoked seizures, which I'll allude to in a minute. So I mentioned provoked. Common provoked seizures can be from infection, drugs, use of the drugs like coke, methamphetamine, alcohol, or withdrawal from those medications can also cause seizures. Sometimes electrolytes, high glucose, high sugar, low sugar, or other electrolytes can contribute to seizures. Kidney problems, liver problems, low oxygen, a lot of medications that we may use in a hospital may lower seizure threshold or cause seizures. Now, what is the epilepsy then? That's when, again, the brain predisposes the person to recurrent unprovoked seizures. Unprovoked, again, meaning that there is no specific cause that we can remove and the seizures won't happen again. So we need 2 of those types of seizures in order to diagnose someone with an epilepsy. In other words, if someone has a one-time lifetime seizure, it does not mean they have epilepsy. Now, what are the causes of the epilepsy? Common causes, usually it can be divided also age dependent, like in children causes different than in adults, than in elderly, but overall common causes are injuries to the head, any type of brain surgeries, stroke, and stroke could be bleeding into the head or clot. Both can put people to risk for having seizures anytime in their lifetime. It doesn't have to be right at the time when the seizures are happening. Brain infections, we call it encephalitis, meningoencephalitis. When there is structural problems with the way the vessels are formed that are not normally developed, we call it vascular malformations, and there's a variety of them. There's also a variety of immune disorders, autoimmune, when there's the body's fighting against its own. Neurodegenerative disorders, and that could be a lot of developmental problems I mentioned in childhood, or could be, for example, in Alzheimer's disease, which is common cause of memory loss, dementia in elderly. The more the disease advances, there is a risk for seizures there too. Malformations are basically a group of disorders when genetically determined problem is causing the seizures. Same as the group of, we call it channelopathies. Basically, these are all group of disorders that are happening during brain development, and it's usually some sort of genetic problem at the cell level. So there's large laundry list of risk of causes that we look for seizures. But in order to make them a little bit more simplified and classify into the groups, we divide them structural. Structural, what I already mentioned, could be stroke, could be tumor, could be anything else. Genetic, when the cells are formed not right, not fully normal. Infections. Metabolic, it's any type of, again, electrolyte abnormalities or liver or kidney problems. Immune, that's inflammatory, and sometimes we don't know. So up to 1/3 of the people with epilepsy while we keep looking for a cause, we never find a cause, or abilities we have at this point in medicine are not enough to point out why someone is having seizures. For us doctors, it's also important to find out what are the, not everything is a seizure, not every loss of consciousness or confusional state is a seizure. So it's important for us to find out when someone comes in and tells them, oh, I passed out, what does that pass out mean? Because there's many other things that may look like a seizure, but it's not a seizure. A very common one is fainting episode, or we call it syncope. And fainting is pretty common from, when blood pressure drops, sometimes from the position changes, extreme heat, or heart problems, or anything that the vessels are not adjusting, people may pass out, which is not a seizure. And then there is transient neurological problems, for example, transient ischemic attack that may look like a seizure when someone may pause, not being able to talk, may appear confused. It's not very easy to figure out right away, especially with one episode, what exactly people feel or do. And then a lot of reactions that are related to movement problems. We call it dystonic, basically, reactions. A lot of kind of twitches, for example, a disease called hemifacial spasm will have twitching of the face, but it's a nerve excitability problem. The brain is doing okay. Sometimes complex headaches, migraine types can look like people are looking at confused, having trouble speaking, and that may, confuse someone for being a seizure. Lots of nighttime, unusual activities that are grouped under parasomnias that can, people may just arouse confused. That can happen pretty much to anyone. Or leg movements that the partner may seem to think, oh, it's unusual jerking activity. And a lot of other psychiatric disorders, psychogenic disorders that need to be differentiated as well. So going back to the seizures, assuming that the history what's provided helps us to determine that this is a seizure, the next question is, where is the seizure coming from? And again, this is very simplified, but there is two main types of seizures. Seizures that arise specifically from a part of the brain, and seizures that are basically arising from both sides, diffusely from the brain. And this is important to know because when we're searching for causes for the seizures and we're searching for any, treatment-wise to fine-tune, this is important to know. Furthermore, what it means, when it's arising from a focus, it's called focal onset. And when it's focal onset, depending how much of the involvement of the brain cells are, people may appear awake and talk to you, but they may have seizure symptoms, or they may become confused. So there is focal aware and focal with impaired awareness. Both can have motor manifestation, meaning, for example, twitchy, jerky activity, or nothing visible, like just having trouble talking but being aware what's going on, or feeling something but being aware what's going on. When we talk about generalized seizures, these are more likely when people will have loss of consciousness, will have jerking, we have sustained posturing. But there's also types when someone's completely awake, like little jerk types of seizures. Sometimes, again, there is unknown. There's always a part that's known. It's hard to sort out exactly where the seizures are starting from. So this is just a longer list of what the seizures may look like. To group them, there could be motor symptoms, there could be feelings such as sensory symptoms, and there could be other things that may look like a seizure or not. But so there's this list of symptoms that we look for. Now, when we're talking about focal seizures, again, focal means it's arising at some part of the brain and not involving the entire brain. The most common type of seizures, or the most common source location for the seizure, is the temporal lobe. Temporal lobe is this green here, and it's responsible for our memory, for our mood, for a lot of behavioral things, so part of the language. So basically, because temporal lobe is responsible for those things, seizures will have manifestation of people having difficulty talking, appearing confused, mood problems. Less common, but other next in line is the frontal lobe, which is actually bigger part of the brain, the frontal lobe epilepsy. And this is, so when we talk about this type of seizures at the frontal lobe, the manifestation of it is different when there's a lot of overly hyperkinetic, very, very active movements, and the patient may be awake, and in fact, they may, this type of seizures occur when someone's sleeping. And then less frequent, less than 10%, is this entire portion, which is parietal and occipital lobe. Again, we say whatever brain is representing, that's the part that that causes issues. Now, about generalized seizures, again, these are arising from diffusely all over the brain, and these are, again, could be classified differently. There's absence, and this is the most common one that people may come and tell, although the way the like petit mal, for example, is worded does not necessarily mean absence, but when we say absence, we assume a staring spell, basically a brief spacing out, and then that may last seconds, and then a person will be fine. And there is specific association when we do brainwave testing, electroencephalography. And then there is the myoclonus, which is very brief jerking, easy to miss, or could come in continuity. And the clonic, tonic are the ones that are most, commonly recognizable when there's sustained rhythmicity. Now, what can trigger seizures? It's always important to look for things that can contribute or trigger seizures, and that starts with lack of sleep. Even someone who does not have epilepsy, if they don't sleep for days and then they stay active, add that to partying, alcohol, anyone is at risk for having a seizure. So lack of sleep is a big thing that can trigger seizures. Others are stress, so stress reduction or stress management is important. Hormonal fluctuations in women especially. Someone who has seizure disorder missing medication is a big no-no. It's important to maintain the medication steadily. Anything else that stresses out the body, fevers, infections, again, drugs that we already mentioned. So those are the ones that can trigger that kind of, if one avoids, then it's easier to prevent. Now, moving on, how do we diagnose the seizure disorder? There's no one single test. And the history is very important. And I always tell to patients, to our trainees, that one time may not be enough to sort out everything. Sometimes repetitive history, collateral information from the family, friends, gives us a little bit more clear picture what has been going on. Because the patient themselves, they may not remember what happened. And so observations are important, collateral history is important. And then the main test we have is electroencephalography, EEG. EEG is basically assessment of the brain function, and it allows to tell whether there is any epileptiform activity. Epileptiform meaning predisposition for the brain to generate seizures or irritability. And then the main tool we have as far as looking for causes is the brain MRI, which has very detailed way of looking whether there's anything that we can point out and say that the seizures are related to that. This is a large list, it's just for the reference, but so you have an idea that there is large laundry list of this one specifically of a variety of genetic disorders that we may search a little bit more in children, but these days with the ability to have genetic testing and additional history, we may be able to fine-tune these things, but it's a lot. This is to show how the MRI helps. Basically, examples of an MRI that, for example, I mentioned the temporal lobe is a common site where the seizures are coming from. And oftentimes we look for a scar tissue. And scar tissue, I mean, when we look for cause for a seizure, it could be very tiny. It's nothing major. It's not a big tumor we're looking for. So it takes a lot of eyes. It takes very dedicated thin-cut studies to be able to point out. And it's easy to miss from one first glance, and then we have to overlook. Anyway, but the common cause could be scar tissue, for example, in a temporal lobe area, and this may be a reason for someone to be having a seizure. Or something a little bit more, it's still tiny, it's in the middle, and this could cause specific types of seizures, for example, laughing seizures, like inappropriate laughters. But sometimes there is bigger developmental issues, so it's obvious things. For example, this is called hemimegalencephaly, which is very rare, but this is how the normal brain looks, like a lot of gyri, sulsation, and this is reflecting how our cognitive function is developed. The more that's developed, the cognition is, that's how brain is developed. As you can see, this side of the brain looks kind of flat. It doesn't have those sulci, gyri, so this entire part is basically abnormal. Or some things like this tiny, it's, as you can see, it's surrounded by white. White is the fluid that surrounds the brain, cerebrospinal fluid, and this is inside the ventricle, basically the pouches of the brain. The simplest way to explain that, this is during the brain development, fetal development. This part was supposed to migrate all the way up to the cortex, but it kind of stayed there, but it's not a normal tissue. So tiny tissue, but it can account for seizures. And so on and so forth. There's a lot of other things. This is, again, tiny, but this is example of a tumor, which actually we didn't realize until the patient had a surgery, because it didn't look like a tumor. It looks like a tiny spot. So this is how the MRI helps us to put things together and see if it makes sense or not. Now, once we diagnose that it's a seizure based on history and additional information, based on EEG, based on MRI, then the next step is to decide, do we treat or not treat, and how do we treat? As I mentioned, if there is a single seizure and our workup, basically the history doesn't suggest any red flags, the brainwave testing does not show anything, it doesn't always show everything. None of the medical tests, as you know, are 100% diagnostic. Sometimes we need to repeat and search. But if first EEG did not show anything and then brain MRI did not show anything, basically there's nothing to point that this person is at risk for seizures. Then we prefer not to treat. And the reason for that is they have only less than 30% chance of having second seizures. That means 70% chance of never having another seizure. So there's no point of treating and committing someone to a seizure medicine. But that math kind of reverses with the fact that if someone has 2 seizures which are unprovoked, then the chance of having the third seizure is 80% and more within the next 2 years. It's not just right away, but we know that there is a high risk to have a seizure. And that's why we always cancel that, even though your tests are normal, your history is very, very suggestive of a seizure, then it's important that you go on treatment. This is when we're clear that it's a seizure. As I said, oftentimes we have to verify, are we dealing with a seizure or not? But if we think it's a seizure, then treatment is necessary after the 2 seizures. When we approach about treatment, there's 2 goals. Seizure freedom. For us as doctors, it's important to kind of aim for seizure freedom. Obviously, for the patient, we always ask, what are the goals? If someone's okay with one seizure here and there, assuming risks are low. But usually we aim for the seizure freedom. And then also lack of adverse effects, and those two are hard to balance. The way we choose anti-seizure medication, it depends on the seizure type. That's why I mentioned that seizure type is important, because that helps us to point out, basically to go on the right track for the treatment. What are the likelihood of side effects in a particular person? And that depends on the age, on other problems people may have, headaches, mood problems, or hypertension, or their own blood thinners. And that's important to keep an eye on. How often we're giving the medications. If, to give a young person, active young guy, like medication to take 3 times a day, they're not going to remember. They're going to miss a dose here and there. So we're going to try to keep a medication that's easier to take, and hopefully once a day or less frequency. Cost is important. It's becoming harder and harder to fight with the insurances. Our office is constantly, that's another job we have, to fight with the insurances to get approval of the medications. So cost and convenience is important. Ideal goal is monotherapy. Monotherapy means we want to give one medication, and that medication works great, and we're done. It's good. So that's the ideal goal. We'll talk about when it's achievable, when not. This is the large list of anti-seizure medications. So the treatment starts with the medications. And the medications help to prevent seizure recurrence. They don't cure the problem. So it's important to take it continuously to prevent the recurrence. And there is the first generation of medications that's been available before 1980s. Some of them are, we're still using most of them, and they're great. But this group of medications have a little bit higher chance of side effects. Second generation medications, larger list with basically some of them I highlighted that are more commonly used in certain populations, but basically all of them are, they work about similarly. It depends on the patient and their side effects. And this is the large list of third generation of medications that came out after 2013. The list goes on. These are the latest 2 medications. And I crossed the Potiga because it came out of market because of its side effects. So we're not going to kind of spend time, but just it's there to be aware. And then lots of medications that could be administered to stop the seizures more acutely. How do these all medications work, and how do we pick the medications? So all the medications work at the nerve endings. They're called synapse, and basically they prevent release of the we call it neurotransmitters, neuropeptides, or they help to release the neuropeptides that are helping to stop the seizures. So there is neurotransmitters that help to activate the brain, and others inhibit, suppress the activity. And a variety of the medications worked on either one point, or they can have different kind of targets to work on at the channels, at the calcium channel, sodium channel, potassium channel, and work on the release chloride channel, etc. This is kind of another way of looking. A lot of medications are what we call sodium channel blockers, and others are the combination. And depending on what we're trying to do, we're trying to kind of hit at different angles. So again, we started the medicine. How many medications? As I mentioned already, it's important to aim for one medicine. That's why we try to pick a medicine which we think is reasonably appropriate for that individual, based on their age, based on their other comorbidities and their preferences. And then of course seizure type is also important. Now, a lot of people actually get controlled with just one medicine. It's just the other part that gets harder to get control. So a lot of people, one medicine is enough. Sometimes we have to go for 2 combinational medicine, and sometimes it's more than 2. But we do know if the 2 medications don't work, then we need to look at the other treatment options, because there's so much medications can do. And then the questions comes for how long to take the medication. So as already mentioned, epilepsy is a chronic disease. So it, basically it means it's lifelong. But that said, some of the seizures, people may outgrow the seizures. There's specific types of, for example, childhood disorders that outgrow. And then medications may help to control, and they don't cure. So if someone stays on medicine, even if lifelong, they may be okay. But some people are actually able to come off the medicine. It just depends how hard it's been to control seizures to start with, how many medications we're requiring, and then of course we're more worried when there's a lot of injuries associated with this, with the seizures. So a lot of things to take into account when we're thinking for how long and whether there's a chance at all to come off the medicine. Just to group the medications also, there is what we call some of them narrow spectrum. That means those are great medicine, but if we use for a wrong seizure type, they may actually make seizure worse. So that's a caveat that we have to kind of remember about when we're approaching which medications to use. And there's, for example, this group, it kind of can be used with both types of seizures, so it's kind of easier to introduce. I mentioned age makes a difference, and for example, in elderly, it's important to take into account the fact that the body slows down, the metabolism slows down, and that elderly take, chances are they're taking other medications, blood pressure pill, cholesterol pill, for the clot, anticoagulant. So those can affect with the seizure medication. So it's important to pick a medicine that does not interfere or interferes the least possible with their standard medicine. But it's also sometimes in elderly, it's important to pick medicine with lower dosages. Because of the slowed metabolism, the levels of the medications can stay higher. Also, the medications are more likely to cause cognitive problems, slowness, sleepiness, difficulty walking, balance becomes important. So picking medications that are going to affect those things less is important. And then picking from one group versus another that has what's called enzyme inducers to avoid, as I said, side effects or interactions is important. Women are another, young women in childbearing age are another important population that we focus on. And the reason being, the young women are young, they're either mothers or going to be mothers, so it's important to consider is there risk if they were too pregnant and for the baby. So we do know there is certain risk grouping major fetal malformations, which is even if someone's not taking any medicine, there's 1 to 2% chance of babies born with a problem. Now in women with epilepsy, that kind of doubles up 2 to 3 times higher, but that kind of depends also on a medicine, the type of medicine they're on. And that's why for us, again, it's important to discuss the planned pregnancy, future plans, ideally try to control seizures before the pregnancy happens to get them on the better medication combinations that are going to be safer during the pregnancy. We also have people use folic acid, which is a vitamin and helps with certain medications and to prevent any complications. That said, if someone's already pregnant, we don't just stop medicine, or they should not, because there's a lot of risks to that. And then there's important close monitoring that's necessary. This is just a list of the pregnancy registries that shows the risk with certain medications. Which basically the key stuff is that some of the medications, for example, lamotrigine, levetiracetam, they're almost basically the risk is as low as general population. But when someone's taking Depakote, valproic acid, then that's Basically, we prefer not to have oxalic acid in any young woman unless we just, we have no choice, and that's usually, it depends on the situation, because there's higher risk of babies being born with problems with that. Now, moving back to the anti-seizure drug efficacy. So I mentioned that we prefer monotherapy, which is, one medication, and it's not bad because about half, 53% of patients will become controlled with that just one medicine. Sorry, under 50%, 47%. But then 53% will continue to have seizures, and that's when we have to change the medicine. And if we changed, there's additional 13% that will become seizure-free. But then after that, we've tried two medicine, the risk goes down dramatically. See, we have only 1 to 3% chance to making someone seizure-free with the third, fourth medicine. We keep trying, but this is the statistics we go by. Which makes about 35% of all people with epilepsy called medically refractory, meaning resistant to the drug management. And by default, us in the epilepsy centers, we have more of those patient populations. So what's the next step if the medications don't work? This is the time to pause and ask a question. Do we have the right diagnosis? Do we have the right type of seizures? Do we know everything about the seizure? Basically, to walk through the checklist I just discussed. But how do we confirm if we have the right diagnosis? It's the key way of doing it is the video EEG monitoring. And the video EEG monitoring is really a way to capture the seizures and then confirm they are seizures, where they're coming from, which is typically done in a hospital. It allows us to confirm the diagnosis, confirm the seizure type, and get enough seizures when we're talking about other outside of medication treatment options. This is what's the setting like. Basically, it's the monitoring room, bunch of computers looking at everyone's waveforms, and this is the basically bunch of electrodes, which is typical to an EEG. This is what us, the doctors, look at. There is the EEG brainwave testing, and then anytime I need to look at the video, I'll pull up the video and see what's going on at the area of the concern. This is how EEG may look like, quiet, and then this is what we call epileptiform activity. All of a sudden there's that high amplitude irritability, epileptiform discharge is what we call. So does everyone need an admission to the hospital for EEG? No. But let's say if the seizures are rare, they're controlled, and then we have the diagnosis, there's nothing additionally necessary, no. But in other situations when there's questions, this is very useful test to get down to the point where we're looking for. EEG also helps sometimes when we need to change medications rapidly. We may do it in a hospital. This is rare, but in some situations it's helpful. Or opposite, if I have a patient who wants to come off a medicine and it's a little bit hard to figure out in the long term, or they want to go back to their lives quicker, we may bring them in, stop the medicine, see if there is any concern, and then decide whether it's okay to leave them off medicine or not. So a little bit of rapid decisions may be done at EEG. Again, this is only sampling of a few days. It's not representing the life, but it can give us an idea. Again, going back to the questions, what do we do next if the medications don't work? Then we evaluate for possibility of surgery, and we'll discuss that a little bit. So this is just all the groups of treatment of epilepsy: anti-seizure drugs, which we already kind of discussed, and then there's surgical options, there's devices, other neurostimulation or neuromodulation, there's dietary therapies specific to certain people, and an alternative is just some of the evidence or not. And this is the diagram we go by. If two medications didn't work, and assuming those were the right medications for that particular person, and they tolerate it, we're dealing with drug resistance or hard to control epilepsy. Then we figure out, is this focal epilepsy arising from a part or is it generalized? And after that, when we know if it's focal, then we evaluate everyone, are these people surgery candidates? And then some people will not be surgery candidates. So if surgery candidate, they go for surgery, assuming we're all on board. I don't know where my slides are running, but if not a surgery candidate, then we look for devices or other palliative options. For generalized epilepsies, it's harder to do what we call curative surgery, completely remove the focus because it's a more widespread problem. But there is what's called palliative surgeries, basically a type of surgery that helps dramatically to reduce seizures, improve quality of life, but it's not going to cure. And then devices, and some of these other devices are now being studied for generalized epilepsies. What else helps us to come up with the diagnosis? Many other tests, and all of them, like I usually tell my patients, it's little pieces of a puzzles that help us to put things together. So a variety of fancy imaging, and then to add to that, this is an easier slide, memory testing, a lot of other fancy tests that we do to be able to point out where the seizures are coming from. And this is how the EEG, the surgical workup may be. Sometimes we use what's called depth electrodes, little electrodes that go in with the holes, through the holes, and help us to sample variety areas of the brain. And we have a robot that helps us to do that. Or we can use bigger openings. The surgeons do bigger opening and place the electrodes right on the surface, and that helps us to map out where the seizures are coming from. Some samples, how the MRI will look after the surgery. It ends up being a little part of the temporal lobe out, this or that, or really tiny ones, like here, very tiny resection. So really it's a small part of the brain tissue that comes out, but it helps with the seizure control. Why do we go for surgery? Because the initial studies in early 2000, but then afterwards many studies showed that actually if someone went for surgery, they have way higher chance of becoming seizure-free, over 60% to generalize, than people who stay on medicine. It's higher even with temporal lobe epilepsies, which I mentioned is a more common cause of an epilepsy. And so on. There's many other studies proving that the surgery helps and potentially cures versus medications. They may work for some time and then stop working. Now, why do we do surgery? Is the life any better after surgery? Again, there is a lot of focus on this, but overall, about over 80% of patients who had surgery, they said their life quality of life was better. It kind of works both ways, so no seizures, and then they have more independence back, but also other things. Mood problems become less of an issue, and then there are studies showing if someone was working before surgery and had whatever they're doing, they're able to go back to at that point in life. Whereas if seizures continue, then memory gets worse, mood gets worse, and it's hard to get back to that reset and pre-seizure baseline. And these are main devices we have for the people who cannot have the surgery. The main devices are vagal nerve stimulation, responsive nerve stimulation, and deep brain stimulation. This is how VNS looks, just a little battery in a chest, and it just sends out the signals. Who would be specifically qualifying for the VNS? As I mentioned, anytime we can do surgery, it's preferred because that can offer cure. But not everyone can qualify for that, because what if the seizures are generalized? They're basically arising more diffusely. Or we have many areas where the seizures are coming from. Or it's hard to point out. A lot of times we keep searching, we place electrodes, but we still can't point out where the seizures are coming from. And some people are just high risk for surgery for other medical reasons. Responsive neurostimulation is a little bit different in the sense that the battery goes in the skull, and then it helps us to actually put electrodes inside close where the seizures could be coming from. So these are when we know where the seizures are coming from, but we cannot do the surgery for a variety of the reasons, because it's risky surgery. People may become paralyzed or have trouble talking, or they have more than one focus. So these are the situations when the RNS, for example, may be more useful. This tool also allows us to actually see the seizures, and not do treatment blindly. And then deep brain stimulation is another way of basically aborting the propagation of the seizures and helping with the control. It has two leads going in around what we call around the thalamus. For dietary therapies, real quick, basically the classic historical diet is the ketogenic diet. It works for very well for specific type of epilepsies. Others may or may not, but there is about good data for improving seizure control in some people. We've now modified into a little bit less strict diet. Modified Atkins diet is an example when there is some allowance of the carbs versus more restriction with the ketogenic diet. So that kind of allows to do that a little bit easier, stick to diet. Adults are harder to stick to the diet. So, and dietary therapies is not just like fancy diets, it has side effects that we need to take into account for as well. It could be constipation, nausea, diarrhea, high cholesterol, and other things that we need to look out for. Now, why are we doing all of this? Again, seizure control is important, not only to prevent ongoing problems, but also it can have immediate risks. People may fall, may have bleeding, break the bones, a variety of bodily injuries. There may be status epilepticus, which is the seizures continue and don't stop. And when status epilepticus happens, there's a very high risk of people both dying from it or not recovering back to where they were. So it's very dangerous, it's an emergency, so we're trying to prevent that. A lot of mood and cognitive problems, social disability in general, inability to drive, lack of independence, relationships, and other things, like swimming problems, cautions with specific sports, and a rare but really a dangerous complication or worry for all of us is also sudden death in epilepsy, which is rare but it happens. And that's about 40 per 100,000 persons per year, and typically higher risk when people have really bad seizures, generalized seizures, long-lasting seizures, hard to control seizures, and other medical problems. Couple more slides. Basically, what is the prognosis? I mentioned that sometimes we just give a medicine and it works and our job is done. And actually, overall, about 60% of people will do well. About 50% of those patients who have been controlled, they may be able to come off seizure medicine. It's hard to predict who is going to have recurrence of the seizures, but again, some of them will be able to come off medicine or simplify the medications. Are the seizures the only problem we have to think about? No, so seizure control is one thing, but then there is all the other psychiatric and cognitive problems that can become a major source of disability, both in children and adults. So, in fact, nowadays the seizure definition or epilepsy is considered as a disorder when there is not only recurrence of the seizures, but also there is a lot of combination of both neurobiological, cognitive, and psychosocial consequences. And that's pretty common. 1 in 3 people with epilepsy will have a type of psychiatric disorder, common one being depression, anxiety, but 1 in 3 we have that problem. And then the reasons for that is really hard to understand. It's not just having a seizure and having depression, and it's a little bit more complex. What are the cognitive challenges? I keep saying cognitive, but it has certain things. That includes slow thinking process, problems with attention, learning disabilities, memory problems, and social isolation in general. Other modifications that are needed for people with epilepsy, driving, obviously seizures have to be controlled. Anything that requires handling of dangerous machinery, working at the heights, extreme sports, baths, those are all a lot of restrictions that are important to be aware of. So just to conclude, epilepsy is a common neurological disorder, and the accurate diagnosis is important to achieve seizure control. Medications help to control and prevent seizure recurrence, but they're not cure. So when the medications don't work, it's important to move on for other treatment. Addressing epilepsy comorbidities is also important to achieve seizure control or get the patient to a better state. Proper assessment at the Comprehensive Epilepsy Center is important to confirm the diagnosis and move on to the next step. Overall, epilepsy surgery is safe with minimal complication rate, and then people who don't qualify for epilepsy surgery, there's other options such as neurostimulations that can help to achieve seizure control. And I'll end with our group that we had a little bit change in the team, but we have a great team. And this is all our doctors, neurosurgeons, our excellent nurse coordinator. And with that, thank you. Any questions? Questions? No.
Could you a number of times you touched on lifestyle, sleeping life? Could you elaborate on that?
Sure. Yeah. So lifestyle, for example, exercise is very important to prevent seizure recurrence. And a lot of people naturally worry about exercise because they assume it may make seizure worse. But actually, exercise helps for general health and also helps to improve brain oxygenation and general healthy brain and prevention of the seizures. So exercise is one important key when we say lifestyle. Stress reduction is absolutely important. Good sleep is absolutely important. So those are examples of a lifestyle modifications that can help to improve seizure control. Sorry, give me a second.
I have an 18-year-old, and so we do have an appointment with you guys, in January. But I want to know, being the mom of someone who's developmentally delayed and more youngster, my worry has been with the transition. Do you guys work a lot with chalk? How do you handle the younger?
Yeah, no, we have a transition care team. We actually have, chalk has the nurse navigators who help with the transitioning. Because the Children's Hospital have much restricted records. We don't naturally get the records, but the transitions of the care team basically sends us everything necessary, and then we keep the communication afterwards, whether with the doctor or through the nurses to sort out everything. And I know it's always stressful for the transition, but we have a process for that.
Great. And then my other question is, do you guys have a good quality of life balance with the actual seizure therapy treatment? Because I really want him to be in an adult facility that also takes quality of life, because sometimes what's the point of having excellent seizure control if you're super aggressive and you end up in jail, for example?
Well, absolutely. That's why we address not just seizures. Of course, it's not everything else as neuro. I mean, we are a little bit limited in resources when it comes to comparing the Children's Hospital, but still we have our psychiatrists and other case managers, social workers can help with that as much as a lot of us also use for aggression mood. We can use certain medications to help to a certain point because we're neurologists. But yeah, we have all the possible resources we can with the insurance restriction and other things. I mean, it's hard to say everything because sometimes there's limitations.
Excellent. Okay, thank you.
The other question?
Oh, how long can people stay on the ketogenic diet? Do they take breaks at all? And I know people can be on it for many years, but
Yeah, so the way approach is it's about 3-4 week trials. If it works, it works. If it doesn't, then we discuss if it's worth stopping or not. Now, if it works, typically we say up to 2 years, and then we're stopping the diet. But you're right, some people stay on it. This is, some things are medically proven, others not. Some people are on it forever and they do fine. But those are more, I don't want to say anecdotal because there's a lot of people, but like 2 years is where we say, okay, let's stop the diet and see what happens. Go ahead.
I have a grandson who's entering puberty, and one of his slides mentioned hormone fluctuations, so contributing to seizures. So would you say that there could possibly be increase in seizure activity due to changing hormones because of puberty?
Yeah, absolutely. During the different stages in life, that can definitely affect seizure. I think women are more studied from that regard. Menstrual cycle, premenopause, menopause, pregnancy. So there's more a little bit focus on that. But absolutely, stages throughout life can affect seizure control.
So we're also noticing some more aggressive behavior and outbursts of aggression type. So would that be an indicator? Maybe looking at some of the change or tweaking in medication. Is there something to address that? Is it by medication only, like you said, by counseling?
Absolutely, yeah. It's sometimes a combination of those things that need to be, addressed. Sometimes it's hard to say which one exactly, but yeah, looking at many different directions, counseling, therapies, in addition to seizure control, looking at the seizure medications, and then just again at whatever stage they are. Teenagers are teenagers, and things like that. Go ahead.
Just to trouble, there are folks here with dogs that can sense seizure. And the way we train the dogs is to give them what they refer to as cocktail of chemicals that they smell. Do you know any? They made it very simple. Some very simple how to predict when seizure is going to come on. But you made it much more difficult. I mean, I don't see connection with what you described and how they describe it to me. So how, in your view, as physician and researcher, how the dogs perceive someone who is
I don't know if I know the answer to that. I mean, dogs are trained, I don't know, certain ways, behavior, like, that the initial stages, this is all assumption, how the behavior of the person changes, even facial well, dogs have whatever extra senses that, I don't know the answer to that, yeah. Thank you.